Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia practice and education. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you have come to join us for conversations aiming to bridge the gap in understanding, knowledge, and implementation surrounding dysphagia intervention. If you're a healthcare professional, a student, or anyone passionate about enhancing the lives of individuals with dysphagia, then you're in the right place. Swallow the Gap podcast is a production of Gap Education, and we are predicated on an unrelenting mission to improve dysphagia care and education. Nothing we say is legal advice. Nothing should be taken without scrutiny. We strive for accuracy, but we do not imply perfection. We value diversity in backgrounds and opinions. Therefore, our guests will not always reflect what we believe. In fact, we may change our minds on topics as we learn more, because this is how progress is made. Through discussion, critical thinking, and open minds, we serve as catalysts for advancement in medically focused speech-language pathology. Welcome, everybody. Today I have with me Dr. John Ashford, Ph.D. He is Education Director and co-owner of SA Swallowing Services in Nashville, Tennessee. He is retired from the Department of Veterans Affairs and as a medical speech-language pathologist and as a professor at Tennessee State University and the Vanderbilt University School of Medicine. He has many professional interests, and if you don't recognize this name, I think you surely will recognize several of the concepts that he's come up with. He is certainly, from the evolution of my learning over years, has become an absolute staple in the work that I do, some of these concepts that he's come up with. And you go pretty far back, Dr. Ashford, I would say. You probably... I consider you to be an OG, as the whippersnappers say now, one of the original gangsters, I guess. What else would you like for these listeners to know about you?
Oh, well, I think, I didn't get my Ph.D. until I was in my 50s. Of course, that was only a couple of years ago. But
Yeah,
right. No, I mean, I was a master's level clinician for many years. And, I was in the trench and I was seeing patients day in and day out. And I think it was what it was all about. And I still do.
absolutely.
I had the opportunity to go back and get more education. And of course, you always find out the more education you get, the less you know. So that has driven me in my own personal interest to go after and look, why do people develop pneumonia from swallowing problems? And that just drove me for years. And so that's really kind of the crux of it. I mean, I've done a little bit of everything in speech pathology as far as medical speech pathology is concerned, but really it's this, and continues to be, even though I'm retired, it continues to be something that I think about a lot, and things I continue to work on is, why do people develop pneumonia from swallowing disorders? It is. It's and the more I know, once again, the less I know.
Exactly. Yeah, I feel like that's how it is with everything. I'm sure I'm going to say 90, 80, 90, 95% of our listeners are familiar with the three pillars of pneumonia from aspiration, or aspiration pneumonia. You are the man for that, right? That's your, I mean, I know you've borrowed from a lot of resources, and we all stand on the shoulders of those who've, gone before us and worked with us, but that's your concept, right?
Well, yeah, it's, I don't like to take full credit for that, because, like you say, it's come from other people, the work of Ortega, Gorbash, Bartlett, people well before me had this idea, but it never coalesced into a concept that we felt like we could work with in the clinic. And it was more academic, it was more researchy kind of things. And this idea of the three pillars came out of in fact, it was a kind of a fluky thing that it came up with the three pillars, because I was doing a presentation at ASHA. And I had to come up with something, I don't know, just out of the blue, I came up with three pillars. But I thought, what are the foundational things that we need to know about, that causes pneumonia? And it's what I struggled with for years. And then that's when I finally found this thing about, poor oral conditions, aspiration, And then, of course, something we were not too prepared for was, hey, the body's health condition.
Yeah.
And by pulling, and I have to say, I talk to a lot of physicians and a lot of people and say, hey, why is it that a guy has a stroke and develops pneumonia? That doesn't make sense to me, or he's eating food. Why food shouldn't make you sick? And so I never got any just real firm answers from anybody. And so that's kind of how this concept, I found this body of information, and then I found this body of information and this body of information, and they all kind of coalesced into this thing. This is what causes pneumonia. These factors have to be there for a person to develop pneumonia from aspiration.
Yeah, that's great. A big soapbox of mine lately has been the idea of function and why we care if someone has dysphagia, why we care if they aspirate, and anchoring back to nutrition, hydration, pulmonary illness or asphyxiation and quality of life. Looking at those things, to me, like that's why we care. If somebody aspirates and they don't get sick and they don't cough their head off and it doesn't affect their quality of life, then who cares? Like, they probably don't care. And if they don't care, I shouldn't care. So, but the thing I like about this is it gives a real boots to the ground practical application of much of the literature that has been put out there. And so it's interesting. I guess I didn't know that most of your background was as a clinician and then you got your PhD later, but it would make a lot of sense because this is such a practical framework. It seems like you're looking at this from the eyes of a clinician and now you're a researcher. You're like, well, how can we bridge this gap into more translational science, making things work for everybody? And I love it. I think we're a clinical degree and we need more things like this that make sense for people who don't have PhDs.
Well, and the three pillars concept is something you take to the patient. You take to the patient's chart. Mm-hmm. And that's what I learned to do a long time ago. I'd go to ICU and I'd see a patient, get a referral, come see the patient for this problem. Well, I took the three pillars with me. I took the concepts with me. I knew what I needed to look at in this patient. It wasn't, was he aspirating or not? That's probably the least of the issues here. And so, I really began looking into how important the immune system is. How is it functioning in these patients? Because, boy, as we know about so many disorders, the immune system is the key. How is it working? And so, I was never taught that. I was never taught, well, the guy's got a swallowing problem. Should you be looking at his immune system? Well, absolutely, I should. And then, of course, this idea of, well, but where does the bacteria come from that's going to cause this pneumonia? Well, it seemed to be common sense as an oral cavity, but for a long time, if you look at the literature, for a long time, and I mean into the 1980s and 90s, even into 2000, there was not full consensus that the oral cavity was the source of pneumonia, and really only on just the last couple of decades have our cardiologists finally decided that endocarditis comes from the oral cavity. And so the oral cavity, that was kind of the last piece that kind of fell into this thing for me. So being able to take the three pillars to the clinic has always been, for me, and still to this day, even with my colleagues I still work with, I don't see a lot of people clinically and all that anymore. But my colleagues here in our company, we talk about those things all the time. And I get a lot of interest and questions from people about those. Really, this is not one of the things that you plan to do. That this whole concept unfolded over years and years and years of interest, and then all of a sudden, here you have it. And I mean, I don't think it belongs to me. I think it belongs to everybody. So.
For sure. But I think you've taken it and making it into something very practical for clinicians, which we can all appreciate. But yeah, no, absolutely not to take away any credit at all from those who have gone before us. That's one thing with this. I mean, there's so many brilliant minds. There's so many people who are trying to do the right thing that I think they step in, they see patients, and they are like, well, I don't know the answer to this. And if they're willing to admit that is exactly what we need to be doing to step in the right direction, to try to get more information. And so they realize how much more complex this is. And they get an idea through all this seeking about what else is it that I need to learn, what else is it that I need to know. But so anyway, I see right now all of these individuals and many companies who are trying to do their work to push us in the right direction to bridge gaps. And so like even in this company, Gap Education, a continuing education and a professional development company, I like if when guests like you come on or guests like anyone else, so you have essay swallowing services, and I think you offer a really good thing. I love it when you plug that because it provides a resource for clinicians to go to become better. And I don't care. I mean, maybe one day I'll offer a fees course. That's great, but you know, you're doing it right now. And I would much rather have this synergism and this symbiosis that's going to push our whole field forward rather than, us be competing individuals trying to stamp on each other. Just let's get the resources out there. Let's get conversations started. Let's let people know what's available because there's so much to learn. And there are a lot of resources, but there's still not enough. We've got to get a greater depth in what we're doing. And I don't even think the research is there for so much of it. So this is great. I really, really appreciate this on
Well,
some.
it's as far as our company, SA Swallowing Services, my wife, Michelle Skelly, is the one who really wanted to do this. And she said, I want to do fees. And, she had a background in nursing homes and hospitals and the whole business. And so at the time, we had a little bit of difficulty finding work for her to do that. And so we started our own company out of the idea that we want to take these services to people. We wanted to go into the facilities. We wanted to take services to people that maybe couldn't get them. Mm-hmm. And so that was really the whole crux of this thing. Then the education component that you're talking about rolled out of that, not because we wanted to do it. It's because people asked for it. Sure. And so they said, hey, can you teach us how to do that? And so we say, well, yeah. And my background's in teaching and that sort of thing. So we put it all together. But I tell you, Tim, things have really, they I don't know how to put this quickly, but people are hungry. And we want to put out a course, and I think a lot of people do. They want to put out their courses that really challenge people. Yeah. It's like in learning fees, for instance. Fees is not that difficult to do, but it's the analysis, and I think that's what you alluded to a few minutes ago. It's what's going on underneath. What's it's aspiration, whoopee. What causes that aspiration? And we need to know the biomechanics. We need to know the physics. Mm-hmm. We need to know the chemistry. We need to know all of that. And so we don't get into a lot of this in our courses, but mm-hmm. we sure allude to it, and we kind of push the clinician a little further to go beyond just, I just see aspiration. Sure. And so we have been pushed by other clinicians to keep our course current and keep pushing this. And I have to say, we have some fabulous people in SAS that are out here, as I speak to you right now. They're out there actually seeing patients, doing swallow assessments and making judgments about what they see and on the lives of people. And they have learned a ton, and they're willing. Our company is willing to share with you. We say, hey, once you take one of our courses or you get in contact with us, we're now family. You contact us at any time you have a question. Yeah. And maybe I'm opening up Pandora's box here, but But the idea is that we are here to push this process on so we can give better care to our patients. That's the whole key: quality of life and better care.
Absolutely. And I'll get, if it's okay, I'll get a link from you and I'll post it in the description so people can get more information on the courses you offer.
Yeah, sure. Oh,
excellent. No, that would be fantastic. One of the things that I really appreciate, and a couple of the things that you've said. So not going into your company first because you wanted to provide education, you put this company out there to meet a need with patients, and then it evolved into something based upon the needs that are out there. And there was something also earlier that you said that was the same idea, like you weren't necessarily sure what it was you were going for. Oh, it was the 3 pillars, but that's what you found that we needed. And so this mindset of following the need and following the science seems very prevalent. So let me kind of turn that back to you now, because I think a lot of clinicians are out there like, I need to grow, but I don't know exactly where it is that I need to go. But this is still, if they have this growth mindset and openness to like, well, whatever that is, I'm willing to find the resources for it. And I'm willing to talk to people and look, where do you think that is? Because you have a lot of experience at an academic level, in continuing education and graduate studies and being a clinician for years and years and years. So I think you've got, if the history tells anything about the future, where do you see maybe some of these needs that are unknown to others are going to manifest?
Well, one thing I don't want to do is scare people off. That's the first thing. But I think for personal enrichment, wanting to know more,
Mm-hmm.
things that are going to help you, I think we need to get individuals need to kind of break out of the box that they've been taught. Aspiration is a big deal and dot dot dot. I think we need to understand more about the human body. Where I really started was, of course, anatomy. I thought I knew something about anatomy, and not everybody likes anatomy. I mean, in our courses, we give a little test at the beginning of the
Yeah.
the course on just anatomy of the pharynx and everything. And out of 23 questions, I think the average is about 7 correct.
Oh, wow.
So, people are not, they're not really tuned in a lot to anatomy. But if you're going to be in swallowing disorders, you've got to be thinking about the anatomical things. So I think that you need to have a good basis for that. Neurology scares people, and it shouldn't. They're just wires, and they go to muscles. And we need to not try to make anything real big out of that. But we know if one of those wires is cut, things don't work well. And so that then leads to the next aspect. And something that I have continued to study over time, and that is basically muscle. Because the reason for dysphagia is muscle weakness, regardless of how you got there. Was it neurological cause, or was it in the muscle metabolism? Was that the cause? We need to understand how muscles operate, because that's the basis of dysphagia. Because weakness in muscles change the physics of swallowing. So when I talk about, you need to learn something about anatomy, you need really go in there and learn about muscles. What happens to a weak muscle? How does a muscle get weak? That's important to know. A person can lay in bed for 2 or 3 days and become deconditioned almost totally.
Yeah.
We need to know that.
And I think with that, there's something else I want to talk about, but I just want to put this out there. I mean, the parallels are there for swallowing too. Patients NPO for 2 to 3 days. There's disuse atrophy. And so that's a big consideration before you go out there and make a recommendation for someone to be NPO, which in my mind can be one of the cruelest and most overused things that we do. Not to say there's never a reason, but consider what can happen as a result of that.
Well, I think understanding basic physiology and pathophysiology at the muscular level is very important to understanding movement. Movement is what pushes the bolus through constriction. We talk a little bit in our courses about physics, not much. I mean, 1 slide maybe, but we're talking about force and pressure, and we're talking about timing, and we're talking about different things like velocity. Now, those are big words, but when you really get down to the clinic side of it, saying, okay, what's going on with this patient exactly? Well, he can't generate pressure. And if you can't generate pressure, you can't move the bolus. So we need to have a little background in that, not a degree, but a little background in that. And then I think the last thing we need to know a whole lot more, and I think you and I discussed this a little bit, we need to know a little bit more about the human body other than from the head up or from the neck up. And I really want to stress that I think immunology if you're going to think about pneumonia, you got to know something about the human immune system. And to me, it's one of the most fascinating things I've gotten into is understanding the immune system and how it plays into this dysphagia thing. It can cause weakness in and of itself. So inflammation is a big thing. So there's a book that I have. If I could, yeah, here it is. I don't get a dime out of this, and I tout this to everyone that I can tell about it. It's by Philip Detmer.
How do you spell that last name?
Immune. Detmer, Dettmer.
Okay.
You can get this on Amazon. It's called Immune, A Journey into the Mysterious System That Keeps You Alive. He is not a physician.
Mm-hmm.
He's not a physiologist, but he talks about, and I have referred this book to many, many, many people. And for SLPs, it will be enormous in understanding the human immune system and how we get pneumonia and how the oral cavity is part of that. I mean, I truly, truly recommend that.
Yeah.
So that's kind of where I think, where we need to kind of expand our thoughts. Mm-hmm. and expand our training to take in some more disciplines so it helps us understand this process.
Yeah, no, very cool. And so I think one of the things about that's intimidating, like you mentioned physics, physiology, neurology, all of these different fields. And to me, it's not like you've got to have tremendous depth and even an undergraduate degree, taking 5 courses in each of these.
No.
There are a lot of basic principles to know, like acceleration and force, a little bit of that,
yes.
and so like a cursory knowledge of some of these things. And I've got a thought on one way to get to that. But even with physiology and muscles and whatnot, and the application of that, like we know weakness and then range of motion in the neurological sensory motor integration that can come with some sensory issues that relate to swallowing, and so I guess there's got to be a sweet spot in there somewhere. We can't just know just a little bit, and we don't have the time to go into too much depth on all of these.
Yourself, you start out with a little bit, mm-hmm. and it's kind of like tasting a bowl of ice cream. You taste just a little bit of it, and you say, "Oh, I think I want some more of that."
You're comparing physics and ice cream. No, I'm just kidding. Physics and you're a nerd. No.
But you just get. I mean, I have to say that's what I've done. I mean, I've jumped off into areas that I have no background in at all. Mm-hmm. Immunology, I don't know what that means, but I kept looking at it, and I'm much more comfortable when I talk about treating patients or what we should do with patients, and when I consult in those things, because I always say, how sick is the patient? Have you looked at their lab values? What does the immune system look like? Mm-hmm. And are they on antibiotics right now? I want to know that. That's one of the first questions I ask when I go see a patient. What do their labs look like? Mm-hmm. Are they hydrated? What's their red blood cell count? I want to know what their oxygen is doing. Now you're thinking, man, that's a far cry from speech pathologists wondering about swallowing, but we're talking about physiology.
Yeah.
And we need to understand that we need to see that in our patient to see where our patient is before we do any intervention with them.
What do you think are some of the most important things to look at within those areas, within lab values? What's the significance of how sick they are?
Yeah, well, where I got started mm-hmm. was the idea that saying, well, he has an infection. Yeah, well, then, I didn't know much about bacteria or viruses or anything like that, and so I kind of got off into it. And somewhere or another along the line, they said, well, if you look at the white blood cell count, it'll tell you he has a bacterial infection. Whoa, really? And that's where I started. And even today, I can't give you numbers, but I can certainly go in and look at a chart and say, hey, does he have a high white blood cell count? That tells me he's got an infection someplace in his body. He's got an inflammatory condition going on somewhere in his body. And that means that his immune system right now is compromised and it's struggling. That tells me this person he's open to getting sick. And so, what happens many times, we get some sort of condition, and next thing you know, we get pneumonia from it. That was what I asked the question: how does a guy that has a stroke develop pneumonia? It's because of his immune system. And that's where I got started. So white blood cell count's important. And neutrophils, if you look at the chart, you look at the lab values, and neutrophils are those immediate indicators in our innate immune system that fight bacteria. So if you have a high neutrophil count, they are racing to that point where there's an infectious spot. And so that's where you want to look. And so those are the things that I look at. That's one of the first things that I look at is, hey, what's his neutrophil count? What's his white blood cell count? And then a lot of times I will look at red blood cell count, because I've had patients that had dysphagia and were come to find out they were anemic. And so you find that out by looking at the red blood cell count. If it's low, that means, hey, they're not getting oxygen. That means if they're not getting oxygen, the muscle fibers are not getting oxygen. And when muscle fibers don't get oxygen, they don't contract properly, and we have weakness. And then what do you know? Now we got stuff slipping down in the airway. So you see how one thing kind of leads to another.
Yeah.
But on the basis, now there are other things to look at, and I won't go into all of that. But those are the two basic things. And once you start looking at those, you'll start looking at other things as well. Albumin's important, those kind of things. So that's kind of where I would start as far as the immune system is concerned.
That's excellent. That's excellent. This is the problem. Every one of these episodes, there's so much that's brought up that I want to go into more on this, and I want to go into more on that. Like, so when you're talking about red blood cell count and limited oxygen into the muscles for cell metabolism and whatnot, I want to go into, let's learn about like some overviews of ventilation and internal and external respiration. Because those are terms that we should know. We should know the difference between ventilation and respiration, difference between internal and external respiration. So gas exchange between the alveoli and the capillaries, and then gas exchange internally between the organs of the body, and getting the carbon dioxide out of there, getting the oxygen in to facilitate metabolism, and the sugar and all that sort of stuff. There's a lot to it. So we need more of that. But I think a really, really good place with this. So you mentioned, excuse me, to this morning, I tell you, I'm having an issue. I thought I drank a lot of water. I'm out here in Utah. It's very dry, especially in the winter when the heat's up, it's drying out the air. I must have drank 25, 30 ounces of water this morning. I guess the coffee just negated it all or something. So I keep muting and clearing my throat and abusing my vocal cords. So I'm sorry, everybody. Give me 1 second. Wow. Okay. So, but with the idea of looking at the white blood count to see if it's high, looking at these different parameters that could be an indication of infection, back to this framework of how that influences somebody's possibility of getting pneumonia from aspirating, and back to the 3 pillars. As I understand the 3 pillars, there is aspiration present. What's the laryngeal valve integrity, in which you, I think, pointed out is probably the least important influencing factor. And then you've got, of course, oral hygiene. And then the one that really, I think, relates to this so much is their immune system status. So would you mind kind of really tying in the idea of infection and their immune system status, and that's influence on whether or not a patient gets pneumonia who we see aspirate in fluoro?
Well, what you have is that anytime you have inflammation, okay, now, if you've got a person that's got some dental disease in their mouth, then you have inflammation. Well, inflammation is actually caused by the bacterial invasion of the tissue, but at the same token, it's also part of the immune system. Inflammation is actually a normal process that comes from primarily neutrophils attacking the area. And so if you've got a mouthful of, or let's say the bacterial load and count in your mouth is high because your mouth is infected, well, that in and of itself does not mean that you're going to develop pneumonia. Because we have normal people walking around that just have horrible cavities, but their immune system is good. Their immune system is, fighting off any type of infection. This might be spreading into the body. So if we aspirate some of this pathogens from the mouth into the lower respiratory system, well, there is. If you've got a healthy person, then the immune properties of the lower respiratory system come into play. They will confront that bacteria. Maybe the mucociliary escalator confronts it, gets rid of it. But even at that, if you've got a pretty healthy person otherwise, and bacteria happens to make it down into the alveoli, that's not a very, very nice place for bacteria to be. It's very hostile because the immune system, the humoral immune system, really takes care of the bacteria down there. Okay, now let's get a sick person, and the immune system of the lungs. First of all, the immune system totally has now affected the person. So we have a little bit increased inflammation. We have maybe more bacterial growth in the mouth in an unhealthy person, and then they aspirate. And then they get into an unhealthy lower respiratory system. So now this person hasn't been drinking any water, and so the mucus system is not as good as it should be. So it's not catching a lot of the bacteria. And then we're also finding that the humoral system down in the lungs, out there in the outer reaches of the lungs, it's not as hostile as it should be. And so what do we have? We have these bacteria that actually latch on to the cells and then cause inflammation there. Inflammation then closes off the air passages, get fluid development, no more oxygen, carbon dioxide exchange, and we get pneumonia.
Yeah. And I mean, there are so many considerations in that too, also with the age of the patient and other things that they've been through. So last week, Rayleigh Denitha Robeson talked about homeostasis, and I think maybe a little bit on homeostenosis, but the idea our body wants to, with homeostasis, it wants to keep equilibrium. I mean, we want our body temperature about 97, 98, and so we do different things to keep this going. When you exercise, your heart rate goes up and you breathe, your respiratory rate's going to go up because you're trying to get more oxygen in and more carbon dioxide out, and your heart's got to beat faster to pump that to all the organs in your body to get oxygen there and sugars there and all the bad stuff out. And so with, of course, homeostenosis, as you get older, your ability to maintain homeostasis, you have fewer functional reserves, and it takes a lot more out of you. And so if you get a 50-year-old healthy individual who gets sick, and maybe their body is fighting an infection with neutrophils and helper T cells and all these other things that are going on in the body, like they might still have a lot of reserves to be able to fight off a potential pneumonia infection, but you get 80, 90-year-old, frail individual in there, that's a lot higher probability. But the idea that if we don't understand the idea that functional reserves wane over time and homeostenosis, this decline in our ability to maintain homeostasis, it's not going to make as much sense either. And so, like, one of the other things I want to point out, so much of this stuff, as you learn more and you learn more, it makes sense. Like I feel like I've been just incredibly fortunate to talk to individuals like yourself and like Rayleigh and so many others, and just getting a little bit of information and being able to integrate that back with what I know and try to understand. I guess what I'm getting at is this does seem like there are so many more layers to it, like it's so much more complicated. But I also want to echo what you said earlier, is that I hope it doesn't scare people off, because I think there is a model. I think there is a model, or I think there are multiple models that can help to distill the information into things that are relevant and applicable to the work that we're doing without us having to go and get a medical degree, right? And so
no, and by all rights, we don't, as as dysphagia specialists, we don't need medical degrees. We just need to have a better understanding of overall body physiology and pathophysiology. And I don't mean a degree in that. I mean, I just recently went to a bookstore at Vanderbilt University and bought a used pathophysiology book in nursing.
Mm-hmm.
I mean, and it's a reference for me, and I go and I look at it, and but no, you don't have to have degrees. But as you take this information and you make it practical, saying, how do I apply this to my patient? Things then begin to make more sense to you, and you feel more comfortable. Truly, it is so huge it will scare you. But how do you eat an elephant? One bite at a time, and that's exactly how you grow professionally. Is that you just continue this lifelong learning of looking at all of these different aspects. It's impossible for a university to train you in all of this. It can't happen. It's got to be once you get out there and start seeing patients and you start asking yourself questions. Now, if you don't ask yourself questions and you don't do lifelong learning, go find something else to do. I'm an old man. I can tell you that. If you can't stay with it and keep learning, then you're not helping your patients, and it's not going to present a challenge to you. And that's how you keep learning, is through the challenges. I'm not on a soapbox. I'm not preaching, but I'm just bringing it to you as I have learned, and as I continue to learn. I'm nearly 80 years old, and I still continue to this day to read papers, and I still continue to think, and I continue to write, and I continue to look at this stuff because it just has that kind of importance to me personally, and that's why I keep digging for it. And that's what you have to do.
Yeah, absolutely. With we also are working against, I'm going to say, I'm trying to be, I want to be very careful in how I describe this, because I think that I don't want to necessarily put too big of a fault on how our education's set up, because it's been a dynamic, evolving process as we start in, speech science and progress to all these different areas. But now we are in 9 diagnostic categories. And this one, I think we truly have encountered an elephant with dysphagia. I think there's a lot more than maybe we realize. Not only are like, oh yeah, let's work with patients with dysphagia because we know about the throat, we know about the vocal cords and that type of thing, but there's so much more to it. And so I think that there's an intrinsic disadvantage within our education because we're covering a lot of breadth in many different areas, but we don't get typical human physiology. We don't get a glimmer of microbiology in our education. I mean, we learn a little bit about the pulmonary system, but if I were to throw this question out at the beginning, do a pretest, what's the difference between ventilation and respiration, internal and external respiration? There would be several people that know that, but there would be, I think, a lot more who didn't. And I don't want to point the finger and say like, oh, that's your fault, because that would bounce off of them and come right back to me, or all the things that I still don't know, so many things, but all the things that I didn't know coming out of school. But how do we still improve this with the educational system for us being to be swallowing specialists, to be better prepared? I think there's still always, no matter what, going to be a tremendous amount of onus on the individual to reflect on what you know and what you don't know, and find those resources and evaluate them and integrate it with what you already know. But how can we maybe boost this up a little bit more to give us a better platform when we graduate, to be able to not be quite as much ownership just on ourselves?
Boy, that's a biggie. I think that there's a lot that can be improved, but it's kind of the way we are set up in our profession, is that there are just so many of us. I mean, so much within our profession that we have to get within, say, a 2-year period of time with a master's degree, and all aspects of communication disorders. But swallowing is not a communication disorder. And so that means that we've got to teach it differently. We've got to teach something. One dysphagia course it's a survey course. Instead, we really need to have curriculums built with a series of courses that talk about the things that you just said. That what do we need to know? These other little things about some microbiology, and we need to know some more physiology. There needs to be a track for that. I know, having worked in universities, that is huge. It's almost impossible to think about, because I'll tell you, once you get something uh, uh, set in a university setting, your curriculum, it's hard to change that. It's very, very hard to change. And in essence, you're actually saying that deglottology here is a new profession, and it's different from communication disorders. And I think we're a long way from that, but I think that there are people out there that I think the same way. We have to be able to make this parting thing into medical speech pathology and prepare people better for that. And we have to take some nursing courses, and we have to take some pre-med courses and things like that, if we think that that's where we want to go. But yeah, that's a hard question, Tim. It really is. Where do you start? How do you do it?
There's so much conversation around that, and I think that it can seem overwhelming.
Yeah.
There was something that somebody said to me once that I don't think I will ever forget. It had to do with this idea of, we just can't, we can't do that. So if you're looking at a process that seems impossible, like a challenge that seems impossible, to me with this, it's not like, well, do we do it or not? Because if we don't do it, then patients suffer by our inaction. So we have to do something to make it better. And so with that, how hard is it going to be? And the idea of someone says, well, we can't do it. We can't do it. This is what stuck with me, that someone else said to me, say, okay, we can't do it, right? Let's just pretend like we can't. But if we could, what would it look like? And so you take out that mental block about this wall that we can't get past, and say, okay, let's just forget about it. We can't do it. But if we could, what would it look like? And these types of conversations are what we need. One thing that I took away from a general physiology class as an undergraduate, there was a brilliant instructor, and I wanted him to teach every part of this class because he really broke it down beautifully. But at the same time, I think he also realized that there were people who knew a lot more than he did about these particular topics, like kidney function. And so he would have other people from the School of Medicine or wherever come in and lecture on this stuff. And so if we're in our graduate studies, if we're tracking this or starting to kind of dig out a track, there's a ton that I don't know, but there are people I can reach out to who hopefully would be willing to talk about this and its relevance to speech pathology. So I think the idea also of thinking that, one faculty member can do it all for a dysphagia course or for a medical SLP course doesn't need to stick.
In my dysphagia courses where I was teaching that, like, I'm not a pediatric person, but I had a person that was outstanding in pediatric dysphagia. And then I had a dietitian come to my class. I had a radiology tech come to my class. I had these people that I felt could certainly put a whole lot more into that course than I could. I knew what my experience was, but these people really knew. And what you learn from them is that they're kind of in the same boat we are. We're out here on the edge, and everyone's kind of learning from each other. And that's the other thing that's going to happen, Tim, is that if universities can't, at this point, put together those types of programs that we want, that's not going to stop people, though, from going out and getting the information that they need if they want it. Mm-hmm. In other words, and I use myself as an example here, I could not find answers, so I went out and found answers. I couldn't get someone to tell me. I had to go out and find it myself. And I think I see a lot of this in people who are out here, been working now for a while on dysphagia, and they're saying, hey, I need to know more. I need to know more. And so they're out there searching for it, and they're out there getting it. And so we're seeing courses develop outside of universities for CEUs that are just outstanding. They're just outstanding courses. But that's where a lot of, I think, we're kind of dragging our universities along, and I don't mean that derogatorily, but literally, I think as we are in search of more information, people they're going to find it. They're going to go out and get it, but it just depends on how they want to get it. And I think we're with situations like this, these podcasts. Hey, what an excellent way of getting information to people. the courses and things like that, things that they would not get otherwise. So yeah, I think that's just the way humans are. They're going to keep digging.
Yeah, especially when you're passionate about something. And I have been extremely impressed with people who are providing, a lot, who have been doing the research in a particular area, who have been around for a long time. Their willingness. I mean, I'm not paying you for this. This is volunteer time because you're passionate about it and you want to make things better. And you and so many others have just been so generous to do these types of things. And it means a tremendous amount to me, not just the passion and your willingness to volunteer time and so on, but one other thing I like to put out there, I like for people to be able to hear these conversations, because coming into this, I had this big perceived power distance between me as the graduate student clinician and the people who wrote my textbooks, or the people who taught my textbooks in the course. And I've just been very impressed with how humble and how unpretentious so many of these individuals are, which this is actually, I wanted to mention this story at the beginning, but I cannot go this episode without mentioning this story. Not too long ago, Dr. Ashford came to Rocky Mountain University for the Hard to Swallow Catalyst for Change and Dysphagia Management Conference. And I remember you had the first thing of the day, you had the first lecture of the day, and there was some miscommunication about which campus it was or something. And so you end up walking a mile to get here in your dress clothes, probably your suit and tie, at least a tie, your dress shoes that weren't made for walking in Utah in the dry air, the elevation you're probably not used to. And you come in sweating and just were so diplomatic. You were so you weren't angry, or you didn't seem angry. You were just very kind about it. And I will remember that for the rest of my days about you, how much I appreciate that. You weren't this haughty academic who came in and like, it's your fault, you didn't do that, casting the blame. But there's so many, I think there's so many good people in our field, and I really appreciate that. And I will never forget that, how pleasant you were about that whole situation. And so hopefully now everybody who listens to this will know how pleasant you are as well, and inundate you with emails and questions, so you'll have an endless thing of work to do.
Well, I want to say just one last thing here, and I've said this for many years. What I know doesn't belong to me. What people know really doesn't belong to them. We're nothing but conduits. We simply are passing along what others have taught us, and we've made sense out of it. So the three pillars concept is not mine. I mean, it doesn't belong to me. It belongs to everybody else. And all it is that I'm taking what someone else taught me and I'm passing it on. None of this belongs to us. And so we should be, that's why I don't mind teaching. I don't mind doing these, because, hey, it's yours to take. And certainly it's mine to give. And I that's why I've always enjoyed teaching. Yeah. And I think that's how we pass information on. But yeah, it doesn't belong to us. It belongs to everybody.
I love it. That's a great philosophy. So for those who want to hear more, we'll post some resources on swallowthegap.com/podcast. So within the episode description, I'll put some more resources there. There is no way to comprehensively cover the three pillars or many of even one aspect of it and all that's involved. And so for those of you who are intrinsically motivated learners, I'll put those resources there. Dr. Ashford, thank you for coming on. Is there anything else that you would like to leave individuals with today?
Well, I'm not a philosopher, so I won't do all of that. But I think what I can say to everyone is that there is so much yet to learn. And really, the best teacher that you can have is your patient. I had a mentor one time, Dr. Robert Wirtz, who said to me, "Come on, John, let's go down the hall here and see what Mr. Smith can teach us today." And so please be open to that, because your real education comes from your patients.
Absolutely. Well, thank you so much. Thank you, everybody, for tuning in. We'll put the information in the description if you want to learn more, and we will see you next week. Thank you so much for tuning in. I truly do appreciate having you as a listener. And as a new podcast, there is so much that you can do to help us grow. Please share us with your friends and colleagues. Even just taking a moment to leave us a rating or a review can help tremendously. Once again, that was John Ashford, Ph.D., a speech pathology clinician, researcher, and educator. I appreciate your time and engagement. Have a great day and a great rest of your week.